Yeah, very good afternoon and all. First of all, I'd like to thank the organizing team, Chairman M.S. Ravi sir and Secretary Dr. Kannan sir, who is my chief and my mentor. Today, I'll be discussing on the role of TMT in CAD. Though with the advent of a lot of newer imaging modalities, both physiological and other various methods, its role is a little bit questionable. Having given this short time, I'll try to make the justification. So the application of exercise ECG have been used in primarily in the screening of the coronary artery disease, and it has also found its application in various valvular heart disease, especially in moderate aortic stenosis and regurgitant lesions, and certain congenital heart disease, genetic cardiovascular conditions, and in evaluating the arrhythmias and the peripheral artery disease. So these are all the some of the physiological responses to the acute exercise, and it decreases the vagal tone and increases the sympathetic tone, thereby increasing the myocardial oxygen demand, and it increases the coronary blood flow. So when the TMT is associated with the imaging modalities, it enhances the information with the imaging modalities like echocardiography and perfusion imaging and CCTA. It the enhanced info to diagnose the coronary artery disease. So we should know the absolute contraindications of when not to do a treadmill or a stress test, especially in an acute MI setting within 2 days. High risk unstable angina, uncontrolled arrhythmias, endocarditis, severe aortic stenosis, decompensated heart failure, acute pulmonary embolism, acute myocarditis, and physical disability. And the relative contraindications: known left main disease, moderate aortic stenosis, tachyarrhythmias, acute complete heart block, HCM with severe resting gradient. But in HCM, to provoke the resting gradient and to see the blood pressure response, it can be used, and of course in mental impairment with limited ability to cooperate. So the terminating absolute indications are the ST elevation more than 1 millimeter in leads without Q waves, and drop in systolic blood pressure of more than 10, moderate to severe angina, CNS symptoms, signs of poor perfusion, sustained BT and other arrhythmias, and most importantly, patient's request to stop. So the exercise-induced symptoms, we should think beyond the ST segment. If the symptoms reported during the test is consistent with the patient's previous symptoms, it is significant. And exercise-induced angina is an important clinical predictor with the severity of the ST segment depression. In patients coming to chest pain unit, the exercise test can be performed after 8 to 12 hours of observation, and it is performed with a symptom-limited treadmill protocol. Stress test importantly addresses the functional capacity. It is a stronger predictor of mortality and non-fatal cardiovascular outcome with and without coronary artery disease. The best method for estimating predicted METs are the following routine simple regression equations. So this is the relationship to tell us the METs achieved on the LV ischemia. With the LV METs achieved more than 10 METs, the LV ischemia is very less, and if it is the METs achieved is less than 7 METs, the corresponding LV ischemia is much more. So these are all some of the parameters in which the forthcoming slides will be discussing about the what beyond the ST segment changes in the treadmill test. So heart rate response, the maximum heart rate provides information about the intensity of the exercise, adequacy of the exercise test, and the effect of medications. So the normally used heart rate maximum is 220 minus age, and it has been replaced with the minimal age predicted heart rate with minimal adjustments. So the chronotropic incompetence, this is the most important, one of the most important parameter. That's the failure to achieve the predefined heart rate with the 85% of the maximum predicted heart rate. It predicts cardiac and all-cause mortality as well as other adverse cardiovascular outcomes. But one thing is, in the presence of any other diagnostic endpoints such as 2 millimeter or greater ST segment depression, exercise-induced hypotension or exercise-induced angina, the heart rate adequacy question becomes irrelevant. And the next one is, another important parameter is heart rate recovery. Abnormal heart rate recovery has been found to be much more important than your routine ST depression because it is mostly governed by the parasympathetic system. So any normal patient and an athlete would recover the heart rate within 30 seconds faster and the remaining in a slow paced manner. So any 12 beats, less than 12 beats per minute after 1 minute with post exercise slowdown, and less than 18 beats per minute after 1 minute with the immediate cessation, and less than 22 beats after 2 minutes. So abnormal heart rate is again associated with the increased all-cause mortality. So the blood pressure response, this is the most important thing. Due to the increased sympathetic tone and the withdrawal of the vagal tone, there is an increase in systolic blood pressure and the pulse pressure and the heart rate BP product and double product reserve. The diastolic blood pressure does not increase, it remains the same. So again, and a most important, exercise induced fall of more than 20 millimeter fall of the after an initial rise or fall below the resting systolic blood pressure is an indication to terminate. It predicts a poor prognosis and it's related to multivessel severe coronary artery disease with the LV dysfunction. So the pseudo exercise induced hypotension is seen in anxious patients. And diagnostic value of ST segment depression has a sensitivity of 60 to 70 and 70 to 80 respectively, the specificity. Any 1 millimeter or greater in horizontal or down sloping, and especially in the lateral pericardial leads are the best defining positive response. Isolated inferior ST segments are not accountable for coronary artery disease. So this is another neglected area like your routine ECG. The lead SCR, AVR ST elevation is an important predictor of any 1 millimeter or greater is an important predictor of a significant left main disease or proximal LAD disease or a multivessel disease. And it indicates also coronary spasm and CAG is indicated. These are some of the normal changes you can see in the treadmill test: rapid upslowing, minor ST depression, and a slow upslowing, horizontal and down slowing. Elevation in a non-Q lead and an elevation in a Q wave lead. So this is another new entity which has been focused by analyzing the mid-QRS analysis. It's a novel marker which can be used adjunct to the ST segment depression. So abnormal high frequency mid-QRS signal increases the sensitivity of ischemia detection from 39 to 69%, and it also increases the specificity from 82 to 86%. Other electrocardiogramic changes, of course, ventricular ectopics are seen in 20% of the patients. Frequent VPCs are seen in 2 to 3%. It can be an isolated VPC, non-sustained VT or a VT. VPCs during exercise or recovering increases the chance of future cardiac events. And VPCs, when noted, and it can disappear during the initial stages of exercise, it does not hold any information. The SVTs are not predictive of ischemia. It might be a marker of a later occurrence of atrial fibrillation. So some of these factors influence the outcome of the stress test, especially digitalis. False positive results can be there and reduce specificity. and negative ST segment response with the digitality is reliable. And LVH and baseline ST depression, beta blockers, bundle block, and WPU, W pattern, all these will influence the ST. Testing in women is very difficult. They have asymptomatic presentation, and in premenopausal women with less than one risk factor has a high rate of false positive tests. But despite that, in the women trial, out of 824 symptomatic women with good exercise tolerance were randomized to TMT with or without myocardial perfusion imaging. The group without MPI had a 48% diagnostic cost saving with no difference in the major adverse cardiac events after 2 years. So the intermediate risk in women who are able to exercise, it holds good in diagnosing the ischemia. These are some of the multivariable prognostic scores. The Duke DTS score is the most importantly followed apart from the Cleveland and other fitness risk scores. It has a higher prognostic information regarding your myocardial ischemia. So this is how the Duke treadmill score is calculated. So in post-MI evaluation, the most of the recent guideline shows both the ST segment elevation and non-ST. The role of exercise test is limited, and it doesn't hold good. A lot of patients are being used in this modality, and it's not routinely advised or advocated by any of the guidelines. It subjects them for repeated revascularization, unnecessary repeated revascularizations in the post-MI. So, if at all, if it is used, it can be for functional evaluation, work and other physical activities, and evaluation of the present therapy. So, the TMT has gone beyond the routine, and it is nowadays used in detecting the CMD, coronary microvascular disease. So, small coronary vasculature is just beyond your routine coronary angiography, and in a patient with the negative stress echocardiography or negative perfusion imaging, it can be used. A positive ETT, particularly if there is an at least 1 minute into the recovery, had a highest specificity for the diagnosis of CMD. So this is a simple test which can be used apart from your routine perfusion imaging to detect the endothelial dysfunction. Abnormal ECG or CMD might be a reflection of the endothelial dysfunction rather than the obstructive situations like your Minoca or Inoca. So when the ETT is positive, when there is moderate severe angina, the sensitivity and specificity are low. When the ETT is positive with ischemic ECG changes, the specificity increases. But when the ETT is positive with persistent ST elevation 1 minute into the recovery, then it holds the more specific for diagnosis of CMD. So, as I said, the post-PCI, it is not much useful. These two trials, especially the Scott and the Promise trials, while testing the functional testing with the anatomical, with the coronary calcium scoring, to evaluate the symptoms concerning for ischemia, 89.8% of those undergoing stress testing and had imaging performed. As many as 60 to 70% of the myocardial perfusion studies ordered for the CAD detections are normal. So this has to be noted. The Promise trial showed that coronary calcium scoring, while not superior, is an alternative to stress testing. And in the further slides, I'll be discussing about the combination of the stress testing with coronary scoring. So is TMT losing its value? Yes, of course, because the ECG changes are much beyond the metabolic perfusion diastolic. It is in the last stage of but all the recommendations or the guidelines, they have different, except the ACC-AHA, it continued to recommend ECG in the most recent 2021 chest pain guidelines. Exercise ECG still receives a class 1 indication. So this is the one which I was telling. It has been combination of calcium score with stress ECG. It provides atherosclerosis information along with key physiological data points, namely functional capacity, arrhythmia detection, and hemodynamic response. This was said by couple of decades, but it has to be incorporated in a patient who can do a stress ECG, and if it is in the intermediate risk patients, this would be of much helpful. So lessons from the courage, ischemia and other trials, they say both the medical therapy and the revascularization holds good as a similar thing. So there is no need for identification of low levels of ischemia. Despite the advent of imaging and other recommendations, still TMT is not going to sink anytime soon. With the adjunctive imaging techniques, whenever necessary, TMT still holds great value in diagnosing CAD, especially in the resource-limited settings like our country. So, finally, the take-home message, you should know the contraindication and the complications before subjecting. Angina is an important clinical predictor. Functional capacity, heart rate response, chronotropic incompetence, BP response are most important clinical predictors. TMT has got limited role post-PCI, post-acute MI, and it can be used for functional evaluation and activity prescription, has definite role in assessing coronary microvascular disease. Calcium stress testing is the way forward. In the resource-limited settings in India, TMT still holds great value with the relevant usage of imaging whenever required. Thank you.